Okay, I guess we can go ahead and get started. Thank you all for coming to this panel today. Today we're going to be discussing neurological emergencies in the PACU and when you should call a neurologist. My name is Ian McCullough. I'm an anesthesiologist at Emory University, and I'm a member of the neuroanesthesiology team. I'm also a fellow of the American Society of Echocardiography, and today I have the distinct pleasure of moderating a very distinguished panel of experts in this field. Dr. Shabana Rajan, Dr. Paul Garcia, Dr. Alicia Sektiv, and Dr. Martin Kraus. They're going to explore some of the most common neurologic conditions seen by anesthesiologists in the PACU, including focal neurologic deficits, spinal cord injury syndromes, seizures, cognitive dysfunction. And each lecture will really discuss the differential diagnosis and post-operative management of these conditions to raise your awareness and confidence when caring for these patients. So with that, I'll turn it over to Dr. Martin Kraus. He is a clinical professor at UCSD on the neuroanesthesia and neurocritical care teams. He holds board certifications in anesthesiology, critical care, neurocritical care, basic perioperative transesophageal echocardiography, and is a testimer in critical care echocardiography as well. He is furthermore credentialed in intraoperative neuromonitoring, functions as the QA/QI director of the Anesthesia Critical Care Medicine Service at UCSD, and is an active member of the ASA. His research focuses on prediction modeling and machine learning for perioperative and critical care outcomes. And today he's going to be discussing why is my patient not waking up, recognizing and treating postoperative seizures. So, Dr. Kraus.
Thank you so much. Thank you so much, Ian, for the kind introduction. It's a pleasure talking to all of you today about postoperative seizures, and I have no financial interests or conflicts to disclose. So real brief, our learning objectives today will be to discuss the risk factors, but also the diagnosis, treatment, and then the prevention of postoperative seizures. So just a brief word about the mechanism of seizures. So if you imagine a group of neurons in a predisposed patient, which basically lost its balance between the inhibitory and excitatory neurotransmitters, and it kind of keeps shooting like in a synchronized pattern, excitatory neurotransmitters, that type of activity can then oftentimes spread over other parts of the brain and then lead to the symptoms which we associate to seizures. Now, in the perioperative world, what patients are prone to it? And the first thing which comes to mind are obviously neurosurgical patients with structural lesions, such as from TBIs, hemorrhages, as well as malignancies. But you can also have a lot of patients who actually have a known diagnosis of epilepsy, which are more prone intraoperatively or postoperatively to seize. And then of those who actually do OB anesthesia, obviously one of the patient groups at highest at risk is the preeclamptic patients, who oftentimes can develop eclamptic seizures. In the remaining perioperative patient population, the risk is quite low. But the factor is that we basically, if you're adding enough risk factors, your seizure threshold can significantly decrease. And this is even the case in elective cases where a patient comes in sleep deprived, possibly in pain, possibly fasting, and then patients who come in urgently for surgery, who are sometimes intoxicated with uppers such as meth or cocaine, or hospitalized patients who are withdrawing from downers like alcohol. ICU patients, especially hypoglycemia and hyponatremia, oftentimes causes of lowering a seizure threshold. In the pediatric patient population, fevers are common causes of seizures. And then the drugs we use can lower the seizure threshold as well. The first which comes to mind are usually etomidate, local anesthetics, but I do want to emphasize that probably more so than the actual drug, it's more of the stage where we're more prone to seize. So if you think about the stages of anesthesia, the excitatory stage is usually stage 2, which we usually experience during emergence, and that's usually when our patients are more prone to seize, and that's actually why the postoperative seizures are more common than the intraoperative seizures. Now, if you think about the symptoms of a seizure, I think most of you immediately have in mind the classic tonic-clonic seizure with high amplitude, low frequency movements. But the truth is that seizures can present in many different ways. You can, for example, have just a very mild, or like just a change in your heart rate and blood pressure. Sometimes it's just a gaze preference. A seizure can basically simulate a stroke where you have a speech arrest. If the temporal lobe is involved, you can have auras such as extreme fear. And then some patients are just completely comatose and you actually don't know what is going on postoperatively, and they are in non-convulsive status. And I just want to highlight that when you have these patients with these very vague symptoms, that there's always the possibility to call an expert like a neurologist or epileptologist and hook up an EEG. I'm not trying to get you to become an expert in reading EEGs when you walk out of here, but I want to demystify it a little bit. So if you can see my cursor, the odd numbers, the channels marked by the odd numbers up here usually represent the left hemisphere. Below here is the right hemisphere with the even numbers. And on the higher part, you can probably see how you have a lot of dysynchronous brainwave activity, while down here you kind of start seeing like a lot of spikes, which are more synchronous. And if you kind of zoom on it, you can actually see the classic spike and wave pattern. And this is basically like a classic epileptiform discharge you can see down here. But these epileptiform discharges, when they start organizing, and they're continuous, and then they start spreading over different channels, even though you can see how the morphology is changing to what initially was more like a narrow complex tachycardia to now a wide complex tachycardia. That's the classic spatiotemporal evolution of a seizure. So when it spreads over time, when it changes morphology over time, but also spreads over different leads, then eventually things are slowing down again significantly because the brain was running out of ATP. And that's exactly the problem. If seizures aren't treated, you're basically creating a demand ischemia because of that hyperexcitable state. Blood pressure and heart rate usually go up because the cardiac output and the cerebral perfusion pressure try to keep up with the oxygen demand, but it can't match that indefinitely, and that's why pretty quickly you develop cerebral ischemia. And around 5 minutes, you actually see cell death, and that's basically why a lot of the 5 to 10 mark is very important, because at that stage, the treatment of seizure, like to determination of seizures, becomes very hard pharmacologically. And at the same time, your morbidity and mortality also increase significantly. And that's why one of the more operational definitions of a status usually makes a differentiation of a status at 5 minutes for convulsive and 10 minutes for an electrographic seizure. So needless to say, you got to treat it as quickly as possible. I don't have to tell you, as a room full of anesthesiologists, how to emphasize the ABCs, but I want to emphasize the first-line treatment that has to be given quickly. By most guidelines, it's usually lorazepam and repeated doses of about 4 milligrams, a benzodiazepine of some kind. The idea here is that you just suppress the seizure as quickly as possible. So you don't really have to wait for someone to get lorazepam from the Pyxis. If you have Versed or Propofol in your pocket, just give any type of GABAergic drug as quickly as possible. And if the patient loses his or her airway, you can always secure it and then later extubate, but you cannot revive that brain. Ask for help, because you're going to need to check labs simultaneously. You have to figure out if there's anything you need to reverse quickly, hypoglycemia being one of very common and time-sensitive causes. And you want to pretty quickly think of the next agent you want to give, usually like a non-sedating anti-epileptic, because either you want to continue to treat the ongoing status or you try to prevent the next seizure from happening. And traditionally, that has been usually phosphonatoin and valproic acid, which was partially problematic in the perioperative patient population because phosphonatoin can lead to a lot of hypertension and bradycardia. Valproic acid can inhibit platelet count and function, so you're a bit more prone to bleeding. So these two drugs have been recently compared in the ACID trial to Keppra, and this Keppra has been shown to be non-inferior, but with a bit more favorable adverse effect profile. So that's one of the newer things which is quite helpful in the perioperative patient population. And if you're unable to break the seizure at that stage, regardless of your treatment, most of the guidelines these days still recommend to proceed with an intubation, to put the patient on a GABAergic drip and burst suppress the patient until the patient can be transferred to an ICU. Now, one important point is once the patient is actually stable enough, in which way that ever is, you broke the seizure or he's now intubated, get a CT head done to make sure there's no structural lesion which needs to be acutely addressed by a neurosurgeon. A couple of special circumstances, intraoperative seizures are very rare because you're usually protected by the general anesthetic, and you oftentimes would also not notice it because you would have to see a convulsion if your patient is not paralyzed. But the treatment will be the same, just with the luxury that you have oftentimes a secured airway. It becomes a bit more difficult if you have someone who's just sedated. The most classic and most risky patient population are awake craniotomies. In awake craniotomies, you basically have someone who's not protected by an anesthetic, and the surgeon is actively resecting and stimulating the brain. So that's the highest risk group to seize intraoperatively, and the treatment is usually that the surgeon obviously stops irrigates the field with cold saline to bring down the metabolic rate. But from there on, you kind of have to continue with the treatment. And the tricky part is that these patients are oftentimes in pins. So airway, like securing an airway can be quite difficult. So you kind of have to anticipate like a difficult airway even before the case has started, in case you do have a patient who is seizing. Other special circumstances, eclampsia, obviously, severe preeclampsia or eclampsia, you want to start load and maintain a magnesium sulfate drip, which is superior to any other benzodiazepine or phosphoenatoin, and avoiding recurrent seizures. Local anesthetic systemic toxicity. Don't want you to forget about lipid emulsions because cardiac arrest is oftentimes imminent. And in delirium tremens, as you know, you can use benzodiazepines, but phenobarbital is actually a nice alternative because it's longer acting and you don't have to redose it as frequently as lorazepam. One important point is if you have a patient who is on antiepileptics coming into surgery, you want to make sure they stay on their schedule, as all these factors can lower your seizure threshold intra-op. So you want to make sure they take it the morning of surgery with a sip of water, and then you want to redose those medications post-op. And in those cases where you're actually still in the operating room and you're due for the next dose, talk to your OR pharmacist what type of drug you can actually replace it with, if it's available in IV formula, or you have to use an alternative drug. Luckily, most of the drugs are available in IV formula, and even though it is not 100% accurate, the conversion rate for those drugs illustrated here is mostly 1-to-1. Last 30 seconds, just a couple of take-home messages. Think of seizures even if you don't see convulsions. Have a low threshold of ordering an EEG if you don't know why the patient doesn't wake up. Time is brain, so treat the patient quickly with whatever GABAergic drug you have available. If you need to intubate the patient, that's fine. You can always extubate that patient, but you cannot revive brain. And don't forget about your anti-epileptic drugs to prevent the next seizure from happening and to stay on schedule if a patient is on those medications at home. And with that in mind, I want to thank you for your attention. Look forward to your questions after everyone has spoken. Thank you.
All right, thank you very much, Dr. Kraus. Next, we have Dr. Shabana Rajan. She is a neuroanesthesiologist at the Cleveland Clinic, program director for the Cleveland Clinic's Neuroanesthesiology Fellowship, a fellow of the ASA, and chair of the International Council for Perioperative Neuroscience Training. And today she'll be discussing awake but unable to speak focal neurologic deficits in the PACU.
Thank you, Ian, for the kind introduction, and good afternoon, everybody. This one?
Oh, either way, if you're going to click over there, that works too.
Okay.
Then start. Yes.
So I'm going to be speaking about a neurological complication that nobody wants to RSVP yes to. So let's start with a case scenario. This is going to set the stage for the discussion. We'll then delve into some background information and then discuss some procedure-related risk factors, etiopathogenesis, and then finally review the recommendations from professional organizations and societal guidelines. So let's start with the case scenario. Imagine this patient who is a 65-year-old Mr. Y. He has just undergone a total hip arthroplasty with conversion to a proximal femoral component. Obviously, they have the usual complications such as previous history of hypertension and remote history of atrial fibrillation, and has been on apixaban, which has been stopped for a couple of days, as recommended. And the surgery took about 6 hours. It was uneventful. He was transferred to PACU. And in the PACU, he's not behaving as was expected. So everything was going according to plan until it wasn't. In the next few minutes, the PACU team finds themselves dealing with an unexpected challenge. As the nurse continues her assessment, it does appear like the patient is awake but unable to speak. And on asking him to smile, there's a facial drift, and he's not able to squeeze your hand, and there is some weakness on the left side. And this situation obviously immediately raises some red flags and concerns. You're thinking, is it residual effects of anesthesia? You're actually hoping it's residual effects of anesthesia. Is it acute metabolic imbalance? But this is most likely a perioperative stroke with all the neurological manifestations. And in our hospital, when a stroke is considered likely, we immediately page this page or number, which is 2 clot. So the stroke team gets page, you get a CT scan, and there you find this hyperdense opacity in the middle cerebral artery. The patient gets rushed into the neurointerventional suite, an emergent thrombectomy is done, and there's reperfusion established. This patient actually had an occlusion of the anterior, the carotid artery where at the takeoff of the ACA and the middle cerebral artery. Following that, they get transferred to NICU and the patient is still not awake, and you can see that there's, on a CT scan, there's lack of gray-white differentiation, indicating that this patient has developed a malignant right middle cerebral artery syndrome, and then he gets transferred to the OR for an emergent craniotomy. So this is the kind of scenario that none of us want to be in, and perioperative stroke can be quite devastating. So this is defined as an embolic, thrombotic, or hemorrhagic cerebrovascular event with motor, sensory, or cognitive dysfunction lasting at least 24 hours, occurring intraoperatively or within 30 days after surgery. And most of the times, these perioperative strokes are ischemic. Occasionally, they can be hemorrhagic. Incidence is 0.1 to 1% of patients undergoing non-cardiac, non-neurological surgical procedures, but the risk can be higher in some select populations. And the 30-day mortality in a patient who has a perioperative stroke is about 8-fold higher than controls. That means those who have perioperative stroke at home and then they get diagnosed quickly and brought in, whereas this patient was undergoing general anesthesia, he was asleep for a long time, and we really don't know when the stroke happened. The likelihood of discharge to a long-term facility is also higher in perioperative strokes, and the risk is highest in the first 72 hours of surgery, and 50% can occur within 24 hours of surgery. So we have to consider factors which increase the risk and consider risk stratification to help identify these patients with an elevated risk of stroke. So these are the SNAC guidelines published in 2020 by Dr. Philip Lysidis et al. And this article discusses what are the preoperative risk factors, as well as they give us some intraoperative guidance to manage these patients. So as far as risk factors, the highest risk remains 1 to 3 days after surgery, but the risk remains elevated up to 90 days. Likely risk factors include the elderly patient, renal disease, previous history of stroke, antiphospholipid antibodies, deficiency of protein C or S, factor V latent deficiency, and heart-related conditions such as atrial fibrillation or a patent foramen OL. As far as procedure-related risk factors are concerned, emergency risk obviously is a higher risk, the risk is higher than an elective surgery and other surgical procedures. All the major thoracic and vascular procedures have a higher risk. As far as metoprolol is concerned, if a patient is already on beta blockers, the guidelines say to continue, but they do recommend that starting somebody on metoprolol, particularly 1 day prior to any kind of surgery, would be deleterious because there's a higher risk of stroke. And all of us are very familiar with the POISE trial, and but the guidelines do say that there is no problem using either esmolol or labetalol. As far as statins are concerned, there is evidence to show that if a patient is already on statins, they should be continued, and this may actually be protective against perioperative stroke. Now, this is the risks stratification, and you have all these various risk prediction scores. The American College of Surgeons risk calculator and the MICA score seems to be highly discriminative for perioperative stroke. If you look at the MICA score, this has 5 components, and it can be because it just has only 5 things that you have to look into, it seems to be a very pragmatic and practical tool for predicting perioperative stroke. This is the American College of Surgical Risk Calculator, and this has about 21 components, so it may take a longer time, but again, supposedly very predictive of perioperative stroke. And the CHAD-VASc was also discussed, I think, in other talks in this conference, and a score higher than 6 is predictive for perioperative stroke. So let's now go to etiopathogenesis. So the usual reason is ischemic stroke more than hemorrhagic, And the reasons could either be hypotension that could have happened sometimes in the intraoperative period, and even the guidelines and some of the articles mention that many times anesthesiologists think that 100 systolic or even a 60 MAP is adequate when it may not be, and that's why you need to understand cerebral autoregulation and monitor for cerebral perfusion. And now, like, there are so many new gadgets coming up where you actually look into these indices to make, because you don't know what blood pressure is adequate for a particular patient. Also, blood loss associated tissue hypoxia can be a problem. Thromboembolic causes such as from cardiac, like atrial fibrillation, or a patient has some atherosclerotic carotid artery disease, endothelial dysfunction, or fat or air embolism in an orthopedic patient have to be kept in mind. So what about this particular patient? This patient did have previous atrial fibrillation, and his anticoagulation was held. He was on apixaban and was stopped for a couple of days, and that is what is recommended. But should he have been bridged? What about, did he have a patent foramen ovale? Did he have an undiagnosed carotid artery stenosis or atherosclerosis? Was it the TXA that was administered which could have caused this perioperative stroke? Was it fat embolism during cementing? Or did he have a hereditary coagulation abnormality like a factor V Leiden? Or was it hypotension and blood loss, which could have been easily corrected but overlooked? So let's look at this article which talks about the effect of TXA on thrombotic events. And it was a systematic and meta-analysis where they looked at, published in June of 2020, and their primary outcomes were stroke and seizures. They looked at about 100,000 patients, and their conclusion was that the tranexamic acid did not increase the risk of thrombotic events in the bleeding patients. However, there was a dose-dependent increase in the risk of seizures, and therefore high doses should be avoided. So it does not seem like TXA is a likely cause for perioperative stroke. And these are the recommendations from our society. The SNAC and AHA, ASA scientific statement. Preoperatively, they say it is better to delay elective surgery for at least 9 months if a patient has had prior stroke. As far as anticoagulation guidelines are concerned, if a patient had been on vitamin K, the recommendation is to stop for 5 days preoperatively, and you can bridge if you consider that this patient has a higher thromboembolic risk based upon the risk stratification score. Now, if a patient is on a direct oral anticoagulant, then the recommendation is not to bridge and just to stop it for 2 or 3 days and then go ahead with the surgery. As far as intraoperative considerations are concerned, the guidelines suggest transfusion threshold of 8 to 9 grams in a bleeding patient with a risk of stroke, avoidance of hypocarbia, which is often overlooked. Hyperventilation causing hypocarbia can cause cerebral perfusion, which is now well established. Consider lung protection strategies, and it does not make a difference whether you use either a TIVA or an inhalational agent. As far as postoperative recommendations are concerned, the American Stroke Association suggests to use this acronym, Learn to Act Fast, which means F is for look for facial drooping or twisting, A for arm or leg weakness, S is for speech difficulty, and T is time to call a stroke code. As already mentioned, time is brain. And just to remember that these signs are often masked by residual effects of anesthesia, opioids, and perioperative changes in cognition can also mimic this. So specific stroke response protocol goals would be to initiate a stroke alert within 5 minutes and communicate with neurology within 10 minutes, treating blood pressure if it is very high, and look at a fingerstick blood sugar and keep a blood sugar goal of 130 to 180, and most importantly, endovascular management. As far as aphasia is concerned, MCA infarction is very likely to cause Broca's aphasia, as happened in this patient, and it's very difficult to predict how this aphasia is going to progress in the postoperative period. What happened to our patient? He was discharged to an LTAC on trach and PEG. He was awake and alert, had a tracheostomy. He was negative for a PFO. and a hypocoagulable workup was ongoing, and he was heterozygous for factor V Leiden and continued to be wheelchair bound in the SNF. So the lessons learned is to be fast, high index of suspicion, and involve the stroke team very early if you have any suspicion. Mechanical thrombectomy is ideal within 24 hours, preferable, and thrombolysis in the if there is no alternative, like you cannot do a mechanical thrombectomy if due to whatever situation the facility is not available, then thrombolysis, but it is contraindicated in specific scenarios. Thank you so much.
All right, thank you, Dr. Rajan. Next, we have Dr. Alicia Sektiv. She's an associate professor at Rush University in Chicago. She's the section director for neuroanesthesiology there, and she's a fellow of the American Society of Anesthesiologists.
Thanks. Of course. All right. Good afternoon, everyone. Thank you for that introduction. So in the spirit of continuing to talk about things that can go wrong in the PACU from a neurological standpoint, I'm going to be talking about postoperative paraplegia and vascular spine surgery. Oh, this one.
Clicker should also work.
Okay. All right, I have no disclosures. So we've all been there. You spend 10 hours in the OR with a complex spine patient or a complex vascular surgery. And as soon as they get to the PACU, something goes wrong. A lot of the things I'm going to talk about during this slide are what we can do to recognize what might be happening and what we should be doing in the operating room to make sure that we don't see this complication. So the first thing we're going to think about is, was there neuromonitoring involved in the case, and were there any changes? So the overall incidence of severe neurological complications after spine surgery is only 1%. And intraoperative neuromonitoring can help to minimize these risks and improve outcomes. Despite the criticism that there isn't really class 1 evidence to support the use of neuromonitoring, surgeons will say that it provides them more assurance that they aren't causing any injury to the nervous system intraoperatively. So what they're hoping to prevent is potential spinal cord insults, such as from compression, from traction, and then early ischemia. And then other common indications for neuromonitoring are those that I have listed on this slide. So we're going to talk about the different kinds of neuromonitoring, but overall, using needle or surface electrodes, an electrical stimulus is applied to a peripheral nerve. So if we're looking at the upper extremities, it's usually the median or the ulnar nerve at the wrist. And if we're looking at the lower extremities, it's going to be the posterior tibial nerve at the ankle. Both motor and sensory components are stimulated. And activation of the motor components are going to result in visible muscle twitches, and the activation of sensory components will result in responses that travel along the sensory pathways toward the brain. Somatosensory evoked potentials monitor the dorsal and posterior columns of the spinal cord, including the dorsal root ganglia. We test these responses at Erb's point, the popliteal fossa, the cervical spine, and the sensory cortex. An electrical impulse enters via the dorsal nerve root and ascends the posterior columns, which mediate proprioception and vibration. The first synapse occurs at the cervicomedullary junction, then crosses midline, ascending to the medial lemniscus to the ventral posterolateral nucleus of the thalamus for the second synapse, and from there it ascends to the sensory cortex. Motor evoked potentials monitor the corticospinal tract. So they are obtained via magnetic stimulation or, more commonly used, transcranial electrical stimulation using scalp needles that directly stimulate the surface of the brain. So the responses are recorded as compound action potentials or via direct and indirect waves in the epidural space. Motor evoked potentials are commonly monitored during critical surgical maneuvers, and a decrease in amplitude is a sign of, or an increase in latency, is a sign of potential damage. Motor evoked potential changes often precede somatary SSEP changes, so they can be more effective earlier to detect motor injury. Transcranial stimulation, as I just described, can cause severe activation of the muscles of mastication. So it's important that when we're doing this monitoring, we have bite blocks in place to prevent injury to the tongue and the mouth. Factors that can make motor-evoked potential monitoring more difficult include diabetic neuropathy, hypertension, any extremes of age, and peripheral motor deficits that are pre-existing. Electromyography is another monitor that's used to monitor muscle activity. This is going to be via spontaneous or evoked compound muscle action potentials. So these are generally performed in areas that are at risk based off of the cranial nerves or spinal nerves that are at risk during the procedure. So spontaneous EMG is continuous, and it's going to be what's identifying any stretch injury or blunt trauma to the cranial nerves or spinal roots. Triggered EMG is going to identify intact nerves that are in the area of the surgical bed. So for example, during a tumor resection, it will be identifying nerves that are at risk that the surgeon wants to avoid. In spine surgery, EMG is thought to prevent postoperative radiculopathies by identifying any nerve irritation during surgery as it's happening. And it's also used to identify malpositioned pedicle screws or pilot holes that may be too close to nerve roots. So the next thing we want to ask ourselves is, was there a block? Now, erector spinae plane blocks are commonly used for spine surgery. They are generally safe and straightforward. It's a regional anesthetic technique where a local anesthetic is deposited between the erector spinae muscle and the transverse process under ultrasound guidance. The local anesthetic then diffuses to the dorsal and ventral rami of the spinal nerves at many levels, and you achieve an extensive multi-segment sensory block. The thought is that they're safer than traditional epidurals or paravertebral blocks because the risk of hypotension and vascular spread and pneumothorax is less. There are, however, case reports of transient paraplegia following these blocks due to anterior spread of the local anesthetic into the epidural space. In most of these cases, though, the issue resolved with motor recovery occurring before sensory recovery. The next thing we want to ask ourselves is, was spinal cord protection deployed? So high-volume aortic surgery centers have developed spinal cord protection protocols that aim to offset the loss of spinal cord collaterals by augmenting blood flow and by augmenting oxygen delivery to the remaining collaterals. So they're used mostly for descending thoracic and thoracoabdominal or aortic repair surgeries. And patients with certain risk factors are more likely to receive these strategies. So patients with very large aneurysms presenting for urgent or emergent repair with the comorbidities listed on the slide, and patients who are hemodynamically unstable at baseline. Now, why do we need these strategies? And we know that the biggest reason is to prevent spinal cord ischemia. So 2/3 of the blood supply to the spinal cord is from the anterior spinal artery, and the other third is from the 2 posterior spinal arteries. The anterior 2/3 contain our motor tracts, which are responsible for pain and temperature sensation, whereas the posterior third transmits proprioception and vibration. The blood supply of the anterior spinal artery is tenuous and depends on supplementation from segmental radicular arteries. The anterior spinal artery also enlarges in the low thoracic and lumbar portions and receives additional collateral flow from intercostals and lumbar arteries and pelvic vessels. The posterior spinal arteries receive significantly more collateral flow, which makes posterior spinal cord ischemia rare and often clinically unappreciated. There is greater anatomic variability in the number of arteries supplementing the anterior spinal artery. And so operative exclusion of these vessels is something that we should be paying attention to attempt to prevent spinal cord ischemia during these cases. Now, the spinal cord perfusion pressure is the difference between the mean arterial pressure and the cerebrospinal fluid pressure. It has been suggested that the CSFP is an important variable that also influences spinal cord perfusion. So during cross-clamping of the aorta, proximal aortic hypertension or increased CSFP may lead to an increase in CSFP, which can decrease spinal cord perfusion and aggravate ischemia. Restoration of this blood flow after unclamping can cause cord hyperemia and lead to a breakdown of the spinal cord blood barrier and subsequent edema. There's also a buildup of lactic acid and other radicals of reperfusion, such as calcium ions and oxygen-free radicals, that contribute to spinal cord injury. So how do we protect against this? So there's many different methods that can be employed. CSF drainage is thought to reduce the pressure related to CSF and increase spinal cord perfusion pressure. The mean arterial pressure can be augmented during the case to greater than 80 to 90. We want to proceed with caution in performing this maneuver in patients with cardiac dysfunction. Transfusion can be considered. The thought is that if we increase our hemoglobin, this will increase oxygen delivery to ischemic tissues. Hypothermia can also reduce ischemic injury by reducing oxygen consumption. And then pharmacologic adjuncts can be used to reduce edema, such as steroids and mannitol. But really, neuromonitoring is considered the thing we do most often in the OR to prevent these kinds of injuries in real time. And finally, let's talk about the spinal. If we're going to place a spinal drain to be draining the CSF during cases or to be to remain in place for post-op monitoring as well, we want to be careful with who we're putting them in and how we're putting them in. So the insertion is simple enough itself. We place these in awake patients who are sitting, usually at L3 or L4, while in using sterile precautions. We want to perform a neurological exam as soon as possible post-operatively when a spinal drain is in place. And it's important to make sure that the drain placement itself didn't cause any injuries before and after. As far as during the surgery, usually the surgeons will dictate what they want us to do with it, but generally we want to limit the drainage to no more than 20 mLs per hour so that we're not over draining. And we want to make sure anytime the patient is being positioned or moved that the drain is clamped so there isn't over drainage of CSF. If there is blood tinged CSF at any time during the case, we want to make sure that this isn't a drain we're just taking out immediately post-operatively. We want to make sure that all of our coagulopathies are corrected if there are any, and that we're doing frequent neurochecks. And then, as with any patient who's having any kind of spine injury or spine issues post-op, we have a low threshold for pursuing head and spine imaging. Thank you.
Thank you very much. All right, last but certainly not least, we have Dr. Paul Garcia. He's an MD, PhD, and is Chief of Neuroanesthesia at Columbia University, Irvine Medical Center. He's a physician scientist who works on integrating neuroscience, anesthesiology, and clinical innovation. His NIH and DoD funded laboratory studies, how anesthesia alters brain networks across age. He also develops clinical EEG practice-based models to predict and reduce risk associated with post-operative delirium. He's published widely in leading journals and co-founded a Columbia-backed biotechnology company that focuses on EEG tools to improve recovery after surgery. He was elected to the board of directors for the Society of Neuroscience and Anesthesiology and Critical Care. Dr. Garcia is recognized internationally as a leader in advancing brain health and focused anesthesia care. So with that, Dr. Garcia.
So thanks so much for having me. I'm a substitution for this. I wasn't aware I was giving this talk before I came to ASA. There was a family emergency for the person that was originally scheduled for this, but it's really great. It's something that's near and dear to my heart. I was medical director of the recovery room for many years at my previous institution, and diagnosing seizures, paraplegia, stroke, and delirium in the recovery room is really important. And what I really like about the talks that preceded mine was how understanding how these problems arise will help you both identify the problems and know what to do about them when they arise. So I'm going to talk about postoperative delirium. The slides may not match entirely because I couldn't change all of them beforehand about, say, a specific protocol about what to do about delirium in the recovery room. So a lot of what I'm going to be talking about will come from my mouth as opposed to the slides. So some quick disclosures is I'm a named inventor on several patents owned by Columbia University related to human EEG. I'm also the co-founder of a spin-off company that has exclusive license to develop some software related to this technology. Their learning objectives are to kind of describe a little bit of the neurophysiologic basis of emergence and recovery from general anesthesia, which will include normal and abnormal emergence and recoveries, and that includes delirium. And then we'll talk a little bit about EEG, but probably not very much in the interest of time. You know, I use this slide because the most recognizable feature of general anesthesia is kind of the abolishment of consciousness, right? And we look at this kind of as an event horizon. And what's kind of interesting about this is, you know, you won't really know somebody is unconscious unless you stimulate them or probe them. And exactly when do we know that our anesthetic is over? If somebody was normal beforehand, and I don't even know if your preoperative clinic are giving them cognitive tests to really determine how normal they are beforehand. My preoperative clinic doesn't routinely do this in everybody. But when is the anesthetic over? When are they back to normal? And these are kind of distinct questions. And they really are important to get at delirium, especially delirium in the recovery room. So even though it's a very, probably one of the largest scientific questions of our time, which is what is consciousness and kind of what isn't consciousness. And that's a very interesting question philosophically. I don't nearly have the time to get into all the details of that. But one of the questions that I'm going to try and approach in the minutes that I have left is, when is the anesthetic over? And that kind of involves, like, what are the neuronal mechanisms involved in regaining conscious awareness, which is one thing that I would kind of define as emergence. And the other one is, what neuronal network physiology must be restored for a brain to return, or at least for you to approximate that it is returning to that cognitive baseline. And this is important because we don't do a good job in our definitions in anesthesia of distinguishing between emergence versus recovery, right? I'll get more into that. Postoperative delirium, it's common, costly, deadly. Infographic from, I believe, anesthesiology. Elderly patients, of course, are more at risk for this. It costs the hospital a lot of money. It is associated with increased, escalation of care, readmission to the hospital, et cetera. And if we can even change delirium somewhere around 10 to 20%, we'd be saving our hospital and our U.S. healthcare system, millions per hospital per year and billions for the U.S. healthcare system. The incidence really goes up not just with age. I'm going to put on my laser pointer here. So, not just goes up precipitously with age. This is work from UC Denver, a guy that used to be at Emory named Mark Moss. But if you don't look for it, you won't find it, right? So you really have to screen for delirium. And we're going to talk a little bit more about that, especially in the recovery room. But this is work from my group. It's published in JAMA Neurology, which shows what's called a forest plot, which kind of shows that, when you have delirium, we did a special kind of statistical method to try and determine that this actually shows that it might have a causative effect on long-term cognitive decline, as opposed to just being incidentally associated with it. So you can look this up in your own time. The DSM-5 criteria is very clear. There's a hierarchy when it comes to consciousness, right? Previous to redoing the DSM-5 in 2013, where they revised the delirium guidelines, they didn't quite have the same view. They called delirium a disorder of consciousness. But now we kind of see that we identify delirium with cognitive tests. Most of these cognitive tests involve language. And if you cannot understand the questions that are being asked to you, or if you cannot speak, or if you cannot hear very well, or if you have neuromuscular blockade on and you can't use your muscles of your mouth, then all of these things can kind of disrupt the way that we are communicating with each other. So first, we have to make sure that your level of arousal is at least enough so that you can focus on the questions that are being asked of you. If your level of arousal is not high enough for that, there are some tests that you can determine to say, is this person still under general anesthesia, or is their level of arousal so impaired that they would qualify for delirium? Then you have to get into their actual answers to the questions. So it's hierarchical. And the reason why I bring this up is because people get very confused about that in the recovery room. I like to say that delirium is a little bit like a test for obnoxiousness. And if you'll excuse the common parlance, I like to say that you can be both drunk and obnoxious. And just because you're drunk, you might be more likely to be obnoxious. But you are not excused from being obnoxious because you're drunk, right? You're still responsible for those actions. There are plenty of people that are obnoxious without any alcohol. And there are plenty of people that can be drunk and not be obnoxious, right? So the delirium is really looking at the obnoxiousness, right? So this really applies in the recovery room. All of our screens for delirium are intended for use in a sedated patient. So you can't say this patient is not delirious, that's anesthetic overhang. This patient is not delirious, they have too much opioid on board, right? It's the answers to the question, it's how are they acting with that opioid on board? How are they acting in the setting of just having recovered from an anesthetic? That is where the delirium is. That's a very important distinction to make. So sedated or delirious? No. All of them are sedated. Only some are sedated and delirious. And really the key distinction is the responsiveness to verbal and or tactile stimulation. Because according to the observer assessment of the alertness sedation scale, right, when you only respond to painful stimuli, in this 0 or 1 level down here, this would be considered general anesthesia or comatose, and you need to use the Glasgow Coma Scale for somebody that's a 0 or 1 here. But all of these other kinds of ones, if you respond after mild prodding or shaking, right? If you are responsive to shake and shout, you are no longer unconscious, right? I'm not saying you're ready to drive home. I'm not saying you're ready to do your taxes, right? But you can say that this person has emerged from anesthesia if their OASS is 2 or above. You can say the same thing about this with your Richmond agitation and sedation scale by looking at the -4s and -5s. And this is really important because, well, why am I not able to advance there? Okay, is how long are these anesthetics in your body for? Well, the truth is that when we do these are studies from a long time ago, halothane, desflurane, even one of our shortest acting one, you can still detect it in the body. And how are you going to say like, oh, if you still detect it, is it still having an effect? Propofol will stay in your body for almost weeks, right? So when are you really back to normal? When is this propofol or this desflurane or this hydromorphone or whatever, if you're taking postoperative pain medicine, when is that no longer affecting you? Unfortunately, our practice guidelines from the ASA really don't make a distinction between emergence and recovery. Every time the word emergence appears, the word recovery is right afterwards. I think that this is a failure of our society and something that we should maybe kind of approach. Because you can have problems in emergence, right? And you can have problems in recovery. And here you kind of see like, open your eyes, take the tube out versus getting ready to go home in the late recovery phase. Delayed arousals are a common problem of emergence. I don't like to use the term emergence delirium because delirium often comes in hypoactive and hyperactive forms. And a hypoactive emergence delirium is nothing but a continuation of the anesthetized state. So you actually first have to have the anesthesia end in order to determine if somebody is delirious. So I prefer to call that emergence agitation, or maybe a hypoactive delayed arousal if it's in the opposite kind of motoric dimension. What's really important for this talk is to talk a little bit about PACU delirium. And I'm going to spend just a couple minutes talking about that. And then we're not going to get really into the persistent neurocognitive dysfunctions besides what I told you about before, which is that all of these things are associated, and the main factor is age and cognitive age. But PACU delirium has really been seeing an increase in research attention over the past few years. We first published on this in 2015 with Pratik Pandey's group. We showed some evidence that you can see some different differences with synaptic transmission by pupillometry in patients that are delirious in the PACU. We did a big review article on this, and then we've also shown that delirium in the PACU is associated with different EEG signals. Dr. Sefavinia is the first author on this. He's in the audience, and he helped us write with this review article. I don't know how the reference escaped the slide, but it's in Current Anesthesiology to really show that emergence agitation kind of lives outside of the typical delirium. And this would be somebody that's like flipping around on your OR table, perhaps because they haven't gotten enough pain medicine. If you were at my talk earlier today, talking about pain and anesthesia, is that if you're flipping around on the operating room table and you are not responding to commands, you're not making eye contact, you don't have your thalamus integrating information from more than one cortical area, which is my definition of the end of anesthesia and the end of emergence. All right, in the interest of time, I'm just going to kind of skip and say that despite the fact that there are a few studies, one in particular, that did not show an association of EEG in preventing delirium, either in the PACU or beyond. That one is a bit of an outlier. And we could talk about some of the issues, why that is, but in a more recent meta-analysis, we continue to show that EEG may be able to prevent delirium both in the recovery room and beyond. And it's all about trying to get that precision medicine for our patients. And I would say before we get into the future, which is going to involve a lot more education on EEG, as far as delirium in the PACU is concerned, you need to have a plan. Would you be willing to give somebody flumazenil that did not receive benzodiazepines beforehand, right? Flumazenil, we heard about post-op seizures, is actually seizure protective. Only if you precipitate withdrawal do you get seizures by giving somebody flumazenil. I've given lots of flumazenil to both animals and humans in the absence of benzodiazepines. It's funny to think about because flumazenil is a partial agonist. It's like the crappiest benzodiazepine that we have. It knocks benzodiazepine off of the GABA receptor, right? But it doesn't necessarily get you agitated or excited. Right, so at really high doses, and Syed is also the first author on this paper, which was a laboratory study, which showed that with a high dose of flumazenil, you can actually start to augment activity at the GABA receptor and really get the animal sleepy. So think about flumazenil early. It's a very, very safe drug. You won't precipitate seizures unless it's somebody that's on chronic benzodiazepines or alcohol or something and you're precipitating withdrawal. Think about things like Haldol. Think about dexmedetomidine. These are really good drugs for some of the different kinds of delirium that you'll see. But if you don't have a protocol for actually screening for delirium, you will miss it in your recovery room, because the more dangerous delirium is the hypoactive delirium. That is these elderly patients that are not giving the PACU nurse any trouble. They're not asking for pain medicine. They're not looking at the clock saying, it's 11 o'clock. Did I really have my surgery already? And kind of saying that those people that have that hyperactive delirium, those are a lot easier to recognize, right? But it's the hypoactive delirium that are associated with escalations of care, not being going home on a rate when they should be, and kind of going along what historians called where the delirium comes from is off of the line in Old Latin when they were plowing. Right? If you would plow off the line because your horse got distracted or something like that with the plow, that's where the word delirium actually comes from, because you're kind of falling off of that normal trajectory. So if that sticks with you, thank you for your time.
All right, thank you, Dr. Garcia. With that, let's go ahead and open it up to questions. If you have any thoughts, any comments for our panelists. Okay, well, I have a few. Oh, we do? Please come up.
Alex Papangelo from Emory. I enjoyed that. So I'm not sure how to ask this. So from a practical point of view, all of us take care of people on the PACU, and the question is always going to be, what's sort of the threshold where you make a call to see a neurologist? And when I think about it, I think about it at many different levels, even from a legal point of view, right? I mean, you may think like, hey, this is not a stroke. Maybe this is recrudescence of a prior stroke, or what's that line? What should we be using? And even delirium can be a little funny. It can cause recrudescence, in fact, too. So I'd love to hear some comments.
Yeah, one thought I personally have on this, and this probably excludes delirium or like agitation, because it can probably like wax and wane in the PACU. But I think one important component is that when your patient doesn't wake up or doesn't move to the extent the patient was preoperatively, I think progression, like continuous progression over the course of the PACU stay is important. So does a patient maybe looks still sleepy, but has possibly like increased like his strength in the next 5 to 10 minutes, maybe wasn't fully oriented when he kind of emerged, but now at least he can answer questions to his name. So if that progression at some point stagnates over like half an hour to an hour, I think I would become a bit more worrisome. If that progression kind of fails and the patient is predisposed to have some type of neurologic complication, be it of like cerebral or cardiovascular risk factors, previous seizure disorder or age, then I would probably consider escalating and consulting.
I would also go back and look at the anesthesia chart and see if there were any long-acting medications given. I've noticed patients not waking up just because we've given some recent dose of dexmedetomidine or perhaps ketamine that we are commonly using now at higher doses. And probably like Martin says, wait for like 15 minutes or so and then have a high index of suspicion whether to scan a patient or not. But most of the time when patients have actually had strokes, like they don't classically present, like what I said, a facial drift and having a patient completely awake and having all these neurological deficits, most likely they're going to be presenting with like delayed emergence. And so I think we need to have somebody in the PACU constantly to monitor these scenarios as they evolve and be on the vigil, I think.
The only thing I have to add to that is also make sure that adequate reversal was given, because that's sometimes also missed, especially in patients who are going directly from the OR to the ICU. I think sometimes we're a little bit more lax about it.
I'd say that most neurologists and psychiatrists, their assessment of sedated patients is inferior to most anesthesiologists. So I think that if it's a matter of dose of analgosedative drugs, I think we should own that. I don't think that anesthesiologists in the future are going to be setting up POCD clinics and following people for months after their cardiac surgery saying, hey, let's try to get you back online after your POCD. But the PACU is a place that we should own. And so when it comes to determining what's going on in our PACU and whether this is a drug effect or not a drug effect, I think that's exactly what we should own. And we should make sure that it isn't a drug effect either by using EEG or, God forbid, a neurologic exam. I think that that's really where we need to get to, because when we have these stroke kind of symptoms, and especially if they're progressing, right, then time is brain and you can't wait at all.
One thing to add maybe, and this is less so to call the neurologist, but just to have the resources readily available. I think what is always taught in our institution that you rather want to overcall and undercall like a stroke code, for example, just to mobilize the CT scan, to get a quick CT hat and CTA. Because at the end of the day, like you're supposed to overcall and rather have like than have like a high false positive rate than ending up with someone with permanent damage because the thrombectomy wasn't done on time. And it's less so that so if your gut tells you that this patient is not waking up as he or she should be, independent of having a neurologist or a stroke attending at the bedside, it's a stroke code will also like just facilitate the resources. And I don't think anyone will blame you for calling a false alert.
Thank you.
Hi, Tammy Van Wyn from University of Washington in Seattle. Do you have like a anesthesiologist, I don't know, crash course like in the PACU when you have a patient like this that doesn't wake up? Like if you have a cardiac something, patients get complaining of chest pain. Okay, we think Mona, right? So we give them, the morphine, the oxygen, and all that, and we order the cardiac panel. Like, what's the quick thing like that for a possible stroke patient? You know what I mean?
Goes fast.
Yeah, I guess, like I mentioned, the fast assessment for facial drift and arm weakness, but also look into the chart and make sure that it's not a residual effect of an anesthetic. But in our
Get anything out of that.
yeah, no, that's true. It is not an easy task. Obviously, what we have is a PACU resident who is all the time there in the PACU watching these patients and alerting the anesthesiologist of the case, and also paging the PACU staff of the day. And so there is more than one person who lays an eye on the patient and at like different time intervals. And I said we probably would wait for 15-20 minutes and review. And, the PACU anesthesiologist discusses with the OR anesthesiologist to see what could be the possible reason why this patient didn't wake up, because the person who did the case would probably know more about the patient than the anesthesiologist in the PACU. And so there should be an active discussion and collaboration going on there. And then, be ready to call the stroke pager if that's what you're thinking. But
Our plan would be like, you're the last anesthesiologist there for the day, and you're the closer, and you didn't do this case, and you're sifting through the chart, and of course go through some of these.
right, and check temperature and glucose and all the other things and make sure if they are okay and the patient is still not waking up. Obviously, I would, patient may be hypothermic and maybe that's why they're not waking up too. So various reasons for delayed emergence. I think we should go through that algorithm.
We have like a group text of all the anesthesiologists, right? And somebody was like, well, this patient's been in for 2 hours. Does anybody have any other ideas? I've done this, and this, and and then eventually the patient.
Right.
I mean, in your example, you kind of said that you probably like took over the case and then you kind of don't really know the patient. I think one of the big keys is if you do have the chance, like just to maybe make it a bit more of a routine to kind of assess the patient, just some simple things preoperatively if you think the patient's at risk. But I think the key is if the patient is not doing anything at all and you're specifically worried about a stroke, I think unilateral symptoms are kind of key. Like if you, for example, let's take your example, the patient doesn't do anything to verbal stimuli. Don't be afraid of like pinching the patient, like at the trap level or at the thigh, and see if the patient is localizing, withdrawing, and kind of comparing how that's progressing in the next few hours. I think I would be very nervous if my patient after extubation isn't doing anything. There's obviously like hypothermia, hypercapnia, those things to be ruled out first. But if you're completely limp patient, I would have a very low threshold scanning the patient and possibly involving neurologist just for the sake of getting an EEG attached. I think if you don't have anything, don't worry about like hurting the patient. He's not going to remember any of that, but it will give you an idea. Okay, 50 minutes ago he was localizing. Now he's intentionally grabbing your hand when you're doing it next time. And next time he's going to complain to you and like throw some words at you, just showing that he's progressing gradually. If you lose that progression or if you stagnate, then I think you just got to image and possibly hook up an EEG.
Yeah, and I would say that I'd add to that, you can look at their pre-op. What's your clinical intuition tell you about this patient's cognitive frailty? Is this somebody that is 75 years old. They have a ton of comorbidities. They're on greater than 5 medications, like the Beers criteria. They, kind of have this cognitive frailty. The person that did the anesthesia, we don't like to throw our colleagues under the bus, but that they get kind of heavy-handed. They don't do a lot of TIVA. They gave the patient 150 mics per kilo per minute of propofol for a 6-hour spine case, and the phenylephrine was at 200 for 6 hours, right? So that person is going to take a long time to wake up. That is somebody that I'd be pinching them, doing all of these kind of things and making sure that they withdraw on both sides from the pain, because then I can be like, okay, this is anesthesia overhang. They are completely unresponsive. They're basically still under general anesthesia, because of this. And, you can have a talk with your colleague, in the future about maybe kind of titrating their anesthetics better.
Having these kind of talks in your grand rounds and other educational discussions also, I think, can keep everybody on an alert in the department to watch out for these complications, I think.
So it is 5 o'clock, but there is one more burning question. So if you guys have to leave, that's okay. But if our panelists could stay a little bit longer, I think this is the last session. So
It's the last session.
yeah, perfect.
Go ahead, Bush.
Go ahead.
I'm Bushra Yassin. I'm one of the residents at Rutgers. So my question is about the non-stroke seizures. For example, sometimes like in emergence, our patients start like bucking, having convulsions. We don't know whether it's seizure or not seizure, and like EEG is not standard of care yet. So usually what we do, like we give propofol and wait until the patient is waking up. But usually if seizure is confirmed, there's like a management that you should, or procedure or things that you should do, like CT, observe for a recurrence of seizure. So this is a question. Second question is, are there do you screen your patients for any risk factors for seizures? Because if there are any risk factors for seizure, like brain frailty, I had a patient with cerebral palsy the other day, and he started seizing in emergence. Luckily, his brain CT was fine, but this patient was under sevoflurane during the procedure. So if we knew he might seize, we probably should change our plan. Instead of sevoflurane, put him on isoflurane or any other management that doesn't cause seizure. For example, TIVA, isoflurane. So are there any screening tools that you consider before you determine your plan for anesthesia? Thanks.
Yeah, two good questions. I think that to answer your first question about the movements we sometimes see, not only in emergence, but sometimes even with induction. I know you guys probably have all pushed the Tomidate without any Versed before, and then you were kind of wondering, okay, was this just some type of myoclonus, or did the patient actually just seize? And to that point, oftentimes, because we have no EEG attached, we don't really know what's going on. I think at this point, we still don't know if a Tomidate just causes epileptiform discharges or full evolved seizures. And I think in that sense, we probably do have a certain degree of very short-lived, temporary, non-recognized seizures during emergence. There's probably a certain number we don't recognize because it's just very hard. And on the other hand, I think we also sometimes, when we do see myoclonic movements, tremors, shivering during emergence, and you guys all know the shivering can just be from the anesthetic, we oftentimes might overcall those movements as seizure-like convulsions. I think the question is, if the patient didn't have any risk factors and it might have not been a short-lived 10-second seizure during emergence, we'll never really find out the truth about it. Doesn't matter in the future if the patient has no other risk factors. It's very important to know that anti-epileptic drugs have a lot of side effects, especially Keppra is very benign in the acute setting, as I said, but it's basically personality changing if you take it over months to years. So overcalling things and then starting someone without risk factors on antiepileptics has consequences to those patients in the long term. So if you're not 100% sure and it has self-terminated and the patient has completed, is basically neurologic completely intact by the end, I would probably hold off further, escalating treatment based on that short episode, because we all are at a slightly higher risk of seizing at emergence. If your patient does not get better after you've seen those movements, Yeah, and I think this is. And I think one key is that a lot of, like 50%, like I think based on class and in ICU patients, 50% of convulsive status goes over into non-convulsive status. So we oftentimes think, the patient just is now post-ictal, but the seizure is still ongoing, the brain is still frying. So if you don't have the improvement neurologically, if you don't see that reassuring improvement in neurologic exam, then you got to act. And then about risk factors, I think the best data, unfortunately, we have is about neurosurgical patients because they have structural lesions like meningioma patients, subdural hematomas. Those are very commonly to seize. And the jury is still out there if those patients should be preemptively put on antiepileptics at the start of induction. There's a lot of debate, and so far we don't have any clear evidence that it could be beneficial. We probably know that some of the more cortical supratentorial lesions are more prone to seize, while some of the post-fossa cases we probably shouldn't worry as much. But I don't think we have any like perioperative risk adjustment besides the fact that we know from like supratentorial cortical lesions such as metastasis, subdural meningiomas, that they have a slight higher risk than someone who gets an acoustic neuroma surgery in the post-fossa.
All right, please join me in thanking all of our panelists.